Good morning once again. We will be starting the second thing, the result. So 8:40, I will start. I've already introduced myself. I'm Dr. Obstetrician. I'm based in Zimbabwe. The two big central hospitals at Mugabe and Hospital. I want to duplicate my screen. Okay, right. I think it's about time we start now. So we start with the talk on ultrasound assessment of the placenta. Ultrasound assessment of the placenta is something that is considered very basic whenever we are doing ultrasound examination. So I'm going to go to basic assessment to highlight some of the placental lesions that we may encounter, and I will discuss briefly some of the contexts that may lead to more detailed assessment of the placenta. To just share with you our experience of the placenta, to say the basic stuff assessment of the placenta. From 19, we noted that about 50% of the placenta, we do not deny that we are a high-risk unit that see a lot of fetal growth retarded babies. But this data led me to think that we need to revise our grading of the placenta and also our ultrasound assessment. As one of my colleagues will show about the grading of the placenta, and these were the placenta position. The most common is placenta positions were actually anterior in about 50% of the cases, and followed by posterior, but only about 1% of our placentas were placenta previa. Vasa previa is maybe 0%. It's not to say there was none, but vasa previa. And we also have got the posterior lobe and the anterior lobe placentas. The reason why the anterior and posterior lobe are not that high is because from our data, most of the second and third trimester, we have very few first trimester onto a low placenta. So whenever we are assessing the placenta, what is it we want in basic assessment? We always want to know the position, the appearance, the placenta function, not really function, but sort of gross assessment of function using Dopplers. The pathology that we may see on the placenta, so the relationship with us. Can be both transvaginal, depending on the circumstances. Of course, if you do have a fundal placenta and the second, third trimester, there is no need for you to say you want to get assessment to check the placenta. But if you have a placenta which is on the low-lying part, or where you are not sure whether it's extending all the way to the internal also or no, you may need to do transvaginal, because that has an obstetric implication. Placenta positions, very easy, as you can see from what we illustrated here from our illustration, that this is an anterior placenta, very easy to locate. Most amniotic fluid is, and we are having a second trimester, third trimester baby, or even first trimester. First trimester may come into inexperienced health, but generally, placenta location in the presence of amniotic fluid, if it is posterior, it should be easy again. So that's a posterior placenta, as you can see demonstrated. This is just the position. I did not put the other position, the lateral or the fundal and so forth. However, when you are looking at my image, it's never easy to say, is it truly like this one? You may not be able to say, is it really an anterior placenta, posterior placenta or not? Because it depends on where my probe is and so forth. It could be a placenta which is probably lateral posterior or so forth. But I'm saying posterior because I did the scan and I know where the placenta was. But the placenta is at the back in this case. The placenta position, the placenta could be low lying. When we are saying it's low lying, we are saying it's less than 2 centimeters from the internal os, as is demonstrated by our image here. We highly recommend that whenever you think that the placenta is low lying, you should check transvaginally. Note that most centers in Africa probably do not do transvaginal assessment, but that is what we recommend. We highly recommend that if you're in placenta assessment and you think it is low lying, do it transvaginally, as is demonstrated on our image here. So I'll give myself a pointer here to just make it easier. So you can see this is the cervix here, and that's the cervix, and this is this yellow tracing there, this orange tracing, and this is the distance from the internal os, which is 17 millimeters. So in this case, a low-lying placenta. Low-lying placenta need to be followed up enough to allow for vaginal delivery. And this is a case of placenta previa. We can see that the internal os, the placenta is touching on the internal os, and this is the cervical canal here and the cervix. So yeah, again, we highly recommend that if you suspect that it's on the low-lying side, do it transvaginally so that you can be sure that indeed it is low-lying. If you don't do it transvaginally, sometimes you may overdiagnose low-lying placentas in cases, because most people who do transabdominal scans, they do it with full blood. The compression of the gas make the placenta appear like it's actually low-lying or even a placenta previa when it is not. So the advantage of the transvaginal scan is that we ask the women to empty their bladders. So we take care of the problem of the isthmus. However, in certain cases, you also have to be aware of the consistency of the cervix itself, the cervical tissue on ultrasound, so that if there is a contraction, because a contraction may mimic, like in this case, if there is a contraction of the isthmic portion of the uterus, this placenta may look like there is a previa when there is none. So this is very important. Just want to clarify again the placenta position. I think when you read our old obstetric books, you may know that there was this classification which says the placenta is low-lying, marginal placenta, partial placenta previa, and then major placenta previa. But I want to make it clear that the placenta is either high, it's a high placenta, or it's a low-lying placenta, or it's a placenta previa. The fact that it's touching or covering the os clinically doesn't change how we manage this placenta. As long as the placenta is touching the os, is placenta previa. Of course, in our reports, we mention by how much it is extending the other side of the uterus. If the placenta is posterior, we normally mention how much it is extending to the anterior part of the uterus. The reason for mentioning that is not to try and grade, but what we are trying to say, to emphasize that we do not, this is a placenta we don't expect to move or to change much to the extent that people may think that the placenta is migrated enough to allow for vaginal delivery. So the point again to illustrate from this diagram is to say the internal os in a closed cervix is a point. So naturally, there is no way you can say you are the placenta. This is just to illustrate to say this grading was being done by people who were passing a speculum and shining some light on membranes which are still intact. That's how this grading came about. In the advent of ultrasound, where we are able to do ultrasound, we are not going to be diagnosing this kind of placentas, but you are going to diagnose them while the internal os is still closed. This is what I want to clarify concerning the old versus new classification. The part of the placenta assessment is the code insertion. The code has to be assessed in terms of where it is inserted. It will be inserted central, which is ideal, which is the good part, where the code is inserted central, or you could have a marginal code insertion, or you could have a filamentous code insertion. All these insertions have an obstetric implication. In a marginal insertion, like in this scenario, this was a case of a bilobe placenta. You can see the other part of the placenta at the top there, and you can see the cord vessels going over to the other part. The cord was actually inserted on the posterior lobe of the placenta. So the implications are these: in that if it is central, this dichotomous branching of the chronic vessels is so that if it is peripherally inserted, attenuation that happens will mean that this chronic plate here will end up being poorly vascularized. And in their paper, in this paper, they noted that this may cause a 10% discrepancy in the birth weight for babies who have a central and eccentric or marginal code insertion. So placenta code insertion has to be assessed. We do it routinely, but I know most guidelines on ultrasound do not probably mention that we should be checking for code insertion. The other importance of doing code insertion is that if it is filamentous, that means it's attached on the membrane. This has an obstetric implication because one of the obstetric practices at delivery is to do code traction. Doing code traction on a filamentous code insertion may lead to rupture of that cord and the woman bleeding while the placenta is still inside. So it has potential to cause postpartum hemorrhage if you miss that the placenta is inserted this way. It just has the same as picking up a bilobe placenta. If you miss a bilobe placenta, people will deliver one lobe and walk away, and the woman will continue to bleed. And probably it is only at post-mortem that people know that there was another lobe of the placenta. Those kind of scenarios do happen in our regions here. And to just summarize and say, you are looking at the placenta, which conditions may cause them to go a little bit digital placenta. They're doing well. Of course, the placenta has to be evaluated. And when you are evaluating the placenta, what is it that you have to look at? First of all, the placenta itself, the span of the placenta has to be assessed subjectively. There is a nomogram which I will show you, which has been proposed for second trimester placenta assessment. But you have to subjectively look at the length of the placenta to say that normal placenta, its longest span normally should not fit within the scanning range, the field of view in third trimester. But if you see a placenta where you nicely, this is not a second trimester, it's a second trimester placenta. So if you can see the whole span of the placenta in its longest span, then definitely you need to think and say, am I looking at a small placenta or not? And we also have to look at the retroplacenta space, which should be very clear. It's easier to visualize the retroplacental space for a posterior placenta. For an anterior placenta, to visualize the retroplacental space, do not apply the pressure. If you apply the pressure on the abdomen with the probe, you are going to obliterate the retroplacental space with the pressure you are putting. So for the retroplacental space, make sure it's easier. Pressure is not going to affect this, so it should be very clear without any hematoma or any lesions in it. It should be anechoic, this retroplacental space, to rule out retroplacental bleeding. The placenta thickness should be measured. Ideally, should be less than 4 millimeters. But again, like I said, there are nomograms. Some books saying, that's what the American, the ACOG, the same in third trimester should be less than 6 millimeters. So in our unit, we use 4 millimeters as a standard to say if you measure the placenta is more than 4 millimeters, the placenta is abnormally thick. Appearance, it should have homogeneous echogenicity. My image on the screen there, it's more echogenic than it should be. I think it's the settings. This was a normal placenta. It was not an echogenic placenta like what is being shown on my image there. So this is these are the nomograms of the placenta thickness and also the curvilinear length, the one I was demonstrating. If you do your length here in second trimester between 20 and 22 weeks, you do your length and you see that it's falling outside, then you can make your conclusion. You say the placenta is looking abnormally thick or it's too thin a placenta. So this is the nomograms. You can look at it later. These videos will be available on YouTube. Then just to demonstrate a thick placenta here, placentalomegaly, and also this is just another preview. You can see the cervix, internal os, the placenta fully seated on it. Then we can see placenta legs here. The placenta legs, if they are less than 40%, they have not been shown to affect growth. Our approach with the placenta legs is to offer these women fetal growth surveillance. So we've been bringing these women for fetal growth assessment whenever we see numerous placenta legs. But if the placenta legs are scanty, there is no reason to really monitor them. So far, even those with significant amount of placenta legs have gone on to have normal normal birth weights, baby birth weights, the ones we have followed up. So it looks like it's in a fairly innocent condition, the placenta legs. But I will differentiate from another condition which I'll present just now. Then we can also have some hematoma happening in the subchorionic space, what is called Breuer small later, where there's bleeding, that's subchorionic. You can see the normal placenta tissue just behind it there. Then we have patients, calcific two kinds of types. We have the plate calcifications here, which normally come as a result of placenta maturation, calcification deposits at the level of the basal membrane. Normally, this kind of calcifications, if the growth is normal, there's no need to do much because it's part of placenta aging in late trimester. However, you may also see these diffuse calcifications like we see on this placenta. If we see these diffuse calcifications, they may be need for us to investigate if a touch screen brought the possibility of touch calcifications, little lots of calcifications on the placenta. There is my colleague who will talk about infection. Then we can also have some lesions called intravenous thrombus, where there is an echogenic rim around an epic area here. These are intravenous thrombus. Again, these are abnormal placenta alterations, which have to be interpreted in the context of whether the baby is growing well or not. Because you will be trying to get the answer to say why is the baby not growing well, especially in the case where the uterine artery, the umbilical Dopplers are normal. And we also have got some placental lesions, the very small, which I mentioned, which is a subchorionic plate bleed. You can see that's a huge clot there, and this is normal placenta tissue. Whenever you see this, you also obviously have to monitor growth to see how this is going to affect the fetus growth. The baby has to be monitored closely. Then we have placenta infarcts. These are small white lesions. You you see there, these are infarcts. You can also see them here. Again, you have to correlate with how the baby is growing. If the baby is well, all you have to do is to monitor. It's not growing. Probably this may explain why, and we meant to assess other parameters, the Dopplers and so forth. Lesion. Then we have corollary regression. We're talking about measuring the placenta size subjectively. You can see that this is the trimester placenta, which is spanning a very small distance here, and it's abnormally thick. So corollary regression is an abnormal formation of the placenta where there's a reduced number of villi, and also reduced number of villi here, and the placenta becomes abnormally thick, and there is engorgement of the intervillar space. So on ultrasound, the placenta becomes very small because the engorged blood in the intervillar space will escape a delivery. So this will be a small, thin placenta, which on ultrasound we will see a placenta which looks big and spanning a narrow distance. Normally, for this condition, the uterinatal Dopplers are normal. So if you see an abnormally thick placenta, which is spanning a very short distance, you're more likely dealing with, of course, you also go other causes of syndrome. Then you've got chronic placenta abruption. You can see this bleeds just in the retroplacental space there. Yeah, then we also got some intra-placenta bleeds, as you can see here again. All these lesions which I'm showing you, you have to interpret them in the context of the baby's growth. If the baby is growing well, you monitor. If the baby is not growing well, you want to investigate further and to closely monitor, see the effects these lesions have on the baby's well-being. Okay, the placenta function can be assessed by doing uterinatal Dopplers. Where we measure uterinatal Dopplers, we can also predict future function of the placenta. If we do first trimester uterinatal Dopplers as part of screening for preeclampsia, and we can also be able to do etiological triage when you are having a small baby who is not growing well and you are wondering what is it because baby not to grow. If we do uterinatal Dopplers and they are that placenta vessels. Thank you so much. This is the end of my presentation. Without wasting much time, I will hand over time to the next presenter, Dr. Zambuko. While he's doing his preparation, let me introduce Dr. Zambuko. He's histopathologist based here in Zimbabwe with extensive experience in surgical anatomic pathology, and he has worked as a consultant now for several years now. He has served at all the 4 central hospitals in this country. He has worked before in Bulawayo at service UBH and Mpilo, and is now based in Harare. He's a medical educator. He has held position as chair of pathology at the National University of Science and Technology and director of pathology postgraduate training at the University of Botswana. He's the current president of the Association of Pathologists of Zimbabwe and has varied research interests spanning and cardiac, HIV, pathology, and cancer in women. He spends most of his time doing surgical pathology at Lancet Laboratory here in Zimbabwe, and also teaching med histopathologists to registrars. We are hoping that Dr. Zaranyika will become our fetal pathologist here in Zimbabwe. We want him to hope this meeting will help him develop interest in doing fetal pathology. So without wasting much time, ladies and gentlemen, let me ask Dr. Zambuko to come through.